Shall we start, sir?
Yes, sure.
Good evening. Welcome to the Next Gen Forum organized by the Young Internist Hub of Sri Lanka College of Internal Medicine. We are having this monthly webinar for this month of May. So the webinar we have uh, organized to obtain clinically relevant insights on selected topics from the expert next generation clinicians. Today, we have a specialist in internal medicine with his interest in palliative care who will be talking about easing the final journey of our patients, how to manage distressing symptoms at the end of life. To initiate today's session, I cordially invite Dr. Krishantha Jayasekara, the President of Sri Lanka College of Internal Medicine, to welcome and address the gathering. Over to you, sir.
Thank you, Sahan. Good evening. It's my great pleasure to welcome you all for the second edition of the Next Gen Forum, a platform dedicated to empowering the voices and vision of the next generation of internists. Today, we gather for an especially meaningful conversation, end-of-life care, a topic that lies at the very heart of compassionate, patient-centered medicine. This webinar aims to provide not only clinical insight, but also ethical perspectives and practical tools to help us grow as healers who can support dignity, comfort, and peace for our patients and their families. We are honored to have one of our young council members, Dr. Pamuditha Madanayake, with us today, who will share his experience, challenges, and guidance on how, as emerging leaders in internal medicine, can approach end-of-life care with courage, clarity, and compassion. May I invite Dr. Sahan Mendis, my energetic young secretary, another young physician who leads the Young Internist Hub, to introduce the speaker in detail and proceed with the webinar. Over to you, Sahan.
Thank you, sir. So let me introduce our speaker today, Dr. Pamuditha Madanayake, MBBS Colombo, MB in Medicine Colombo, MRCP UK, MRCP SCE in Palliative Medicine, Geriatric Medicine, Acute Medicine, Diabetes and Endocrinology, who has graduated from the Faculty of Medicine, University of Colombo in 2009 with exceptional results. He had his postgraduate training at NHSL and Colombo South Teaching Hospital. He completed his postgraduate training at Oxford University Hospitals in the United Kingdom. He became a board-certified consultant in internal medicine in 2017. The same year, he obtained MRCP UK, and he has also completed MRCP specialty certificates in acute medicine, geriatric medicine, diabetes and endocrinology, and especially palliative medicine. Currently, he is working as a consultant physician in internal medicine at Base Hospital, Kalawan. His special interests include palliative medicine and end-of-life care. And he is also a council member of Sri Lanka College of Internal Medicine. Today, Dr. Pamuditha Madanayake will talk to us about easing the final journey of our patients, managing distressing symptoms at the end of life. Before inviting Dr. Madanayake to begin the lecture, let me inform all the participants that we take the questions at the end of the lecture, but you can put your questions during the lecture and also during the Q&A session in the chat. And regarding CPD points, so each participant will get one CPD point. So at the end of the lecture, during the Q&A session, I will display a QR code which link to a Google form. Please make sure you fill the Google form so that you will receive the CPD certificate automatically. So at the same time, we will share the Google link to Google form as well. So you can use either way to respond to the Google form. Following these messages, without much delay, now I invite Dr. Pamuditha Madanayake to deliver his lecture. Over to you, Dr. Madanayake.
Thank you very much, Dr. Sahan, for that very kind introduction. I want to thank Dr. Krishantha Jayasekara, the President of Sri Lanka College of Internal Medicine, for giving me this opportunity. Sorry, giving me this opportunity. So I'll start the lecture. First of all, I'm going to switch off my video. Okay, I hope you all can see my screen now.
Yes, Pamuditha, yes, we can see, yes.
Thank you, sir. Okay, so ease in the final journey. As the name implies, we are going to talk about managing distressing symptoms at the end of life. So just a brief outline of what I'm going to talk. The scope of today's talk is mainly about managing the final hours of a patient, although end of life by definition includes the last 1 year of life in a patient who is dying from an incurable medical condition. So we will discuss about what is a good death, what are the distressing symptoms at end of life, and their treatment options. I'll go through some case scenarios that we have encountered during our clinical practice and discuss specifically how to manage these symptoms. I'll also brief you about anticipatory medications that we use in end of life and introduce you to the syringe drivers, which is a great help in managing end of life patients. So to start off, I'm going to start with this case scenario. It's a 64-year-old man who was admitted with acute loss of consciousness. We've done a non-contrast CT scan of the brain, which shows a large left-sided intercerebral hemorrhage with the intraventricular hemorrhage and a midline shift. We have obtained neurosurgical opinion, and they very correctly said this is for conservative management. There is no benefit of going for surgery. He has a GCS of 9 E2 M5 V2, and his vital signs, he has a bit of a temperature. He's hypotensive, bradycardic. His oxygen saturation is 88% on room air, so he's having low sats, and he has right side lower zone crackles. So this is the patient who comes to the medical ward after ETU getting the advice from the neurosurgeons. So what will happen next? So the patient is connected to the cardiac monitor, and because of the low blood pressure, the blood pressure cuff is set to monitor the blood pressure every half an hour. Started him on oxygen via the face mask and aiming at saturation of more than 94%. Started him on some fluid. It was a very difficult venous access. So multiple attempts for the second cannula were failed, but finally with the help of the ultrasound, he got a second cannula. Started on noradrenaline for the low blood pressure. He was started on IV meropenem for fever and possible aspiration. As patient is unconscious, an NG tube was inserted, but the poor patient was trying to remove the NG tube. So both hands were tied to the ends of the bed. 2 hours later, he had a cardiac arrest. The team were very proactive, quickly managed to start CPR, had a tube down his throat, ambu ventilation started, but after a few cycles of CPR, decided to stop the CPR because it was felt that further attempts would be futile, and the patient passed away. So, is there anything wrong in this management? It's very difficult to like pinpoint and say that they have done something wrong. legal point of view, they have done probably the best they could. But is there an alternative approach? Is this the only way to manage this situation? So I'm going to now discuss a few points about what else we could have thought about. So in this scenario, it was very clear that the prognosis was extremely poor and there was no chance of a good quality life after this event. So what are the priorities at this situation? Is it to extend life or to prioritize comfort? I'm just going through a definition of what is a good death before moving on to an alternative approach to that patient. So this is the Institute of Medicine report, which is the most used definition of a good death in medical practice. So it says, a good death is one that is free from avoidable distress and suffering for patient, family, and the caregivers. In general, accord with the patient's and family's wishes, and reasonably consistent with clinical, cultural, and ethical standards. So there's quite a bit in this term of good death. But important things would be like we are avoiding distress and suffering of both the patient and the family. We are staying in line with patients and families' wishes as well as clinical, cultural, and ethical standards. So, in addition to the clinical significance in a patient with acutely unwell clinical scenario, there is emotional, cultural, and ethical importance that we need to address. So the goals of treatment, when the goal is not to cure the patient, still there are goals. The goals are comfort, dignity of the patient, and also trying to do as much as the patient's wishes. Okay, so having them in our mind, let's go back to the case scenario again. He's a 64-year-old man, a retired teacher, who was admitted with acute loss of consciousness. CT has shown a large intracerebral hemorrhage with very poor prognosis and not for any surgical interventions. His GCS E2M5V2. Does this number have any more importance than saying his GCS is low? So in each department, he has responded to pain. So what we know is he's definitely sensitive to pain. He can feel the pain. He's opening eyes. He's trying to localize and he's trying to verbalize for pain. So he's definitely sensing pain. Of course, his vitals are pretty bad. He is probably in sepsis as well. We got a bit more history from the patient. So he was a fiercely independent guy at the age of 64. He was driving, doing all his work by himself. He hated coming to hospital. He's a guy who hated doctors. And in the past, when when they saw somebody who was on a wheelchair, a relative, he has told that if he were to be in that stage, he would rather die than be on a wheelchair. Very few information, but very important at this stage to make a decision. So what we really did, how we managed this patient. So we'll go through step by step. So we had a good discussion with the family and we have agreed on priorities. I will emphasize more on next slide on what we discussed. But the the priorities were to make sure he was comfortable. We put him on a bed at the corner of the ward because we don't have separate rooms. And we put curtains around and got the family members to sit at the bedside. There was some privacy, the maximum we could provide, with some private space for the family. We stopped monitoring. We did detach him from all the monitors, saturation probes. We just gave some oxygen through the nasal cannula because we thought the face mask was distressing him. The son brought the Buddhist monk from the local temple and had some pirit chanting because this is something he really entrusted, and he was a very religious person. In 2 hours' time, again, he passed away. Wife was holding his hand, and there was no CPR. So there was a big difference in the two ways, the two approaches of managing this patient. Although on paper, there was nothing wrong legally on either of them. So discussions with the family at end of life is a very difficult and a situation which needs quite a lot of practice. So the baseline, the most important thing here is to establish what will be the patient's choice if they could decide. So it's not correct to ask, say, the son, what do you want us to do to your father? So, because that's going to create a lot of bias. So he will think if I say like, just let him die, he will be committing a big sin. So it's more than asking what they want. The discussion should lead to the point where we discuss what will be his decision if he was able to make a decision at this stage. Another key message is, if we are not going to act on monitoring or investigation, it's best not to do them because it has some distress, especially blood pressure coughing will have quite a big distress in a patient who is sensitive to pain, like our patient. We can always stop medicines that we think are not in patient's best interest. We shouldn't be shy to stop a noradrenaline, but if that decision is very difficult, what we could do is once one vial of noradrenaline finishes, we can, of course, not restart it, just let it be. The oxygen should be given at this stage only for comfort because we are prioritizing comfort and we are not going to achieve any target saturations because it's not going to mean anything at this stage. We have avoided pain from multiple ways. The blood pressure coughing if he was on the monitor, cannula attempts, putting an NG tube, which is very distressing, restraining the patient to keep the NG tube in place, the CPR, which will invariably cause rib fractures, and intubation. So we had avoided quite a lot of scenarios which could have caused pain to this patient. And of course, a thing to remember is like religious rituals, again, different people have different views. So it's important to know what the patient's wishes would be because we shouldn't bring in someone like a monk if they are not religious and like they hate the monks. So it's again a very personalized thing. I'm just going to quote some paragraphs from the SLMA end of life guidelines. So one paragraph says, although withdrawing treatment may be more emotionally challenging than withholding treatment, ethically they are not different. And again, the SLMA guideline says the doctor should not allow his or her anxieties to override clinical judgment in the decision of withholding or withdrawing treatment that is not in the best interest of the patients. So both these paragraphs were quoted from the SLMA end of life guidelines, which is available online on the SLMA website. Let's move to case number 2. So it's an 88-year-old man with COPD. He's almost bedridden due to the breathlessness, and he got admitted with an exacerbation of his COPD. On arrival, he was in type 2 respiratory failure with a gas showing acidosis, and he is not tolerating NIV. The wife was with the patient, and her main concern was the noisy breathing he was having. Again, a situation where we have possibly two approaches, but I'm going to discuss what's best in view of patient's best interest. So the management of this patient who's having COPD likely at a terminal event now. The first step is, of course, identifying he is actively dying. Discuss with the family. Let them know that he is dying. And then establish goals, what we need to do to make him comfortable. So again, stop all the monitoring, stop doing further investigations because it's not going to change the outcome. Oxygen only for comfort. I'm telling them again to emphasize these basic steps in managing end-of-life patients. And the most important thing here is to treat the breathlessness because he is suffering from breathlessness. We can't reverse his damaged lungs, but of course we can treat the breathlessness. What is the drug of choice in this situation? It's morphine. If he can take oral, then we have either morphine immediate release tablet or the solution. Whatever is available at that setting is okay. And we can give 2.5 to 5 milligrams, and we can repeat every 2 to 4 hours depending on the improvement of symptoms. But if they can't take orally, which will be the case in most scenarios, then the best way to administer that would be subcutaneous route. We use a butterfly cannula in the subcutaneous fat in the abdomen, so it will prevent repeated punctures. And then we can use this cannula to give morphine whenever needed. So these subcutaneous lines, the butterfly cannulas, can stay up to 7 days if they are maintained all right. And of course, when somebody is very breathless, it invariably is accompanied by anxiety. So giving some midazolam initially will also help with the anxiety, which will exacerbate the breathlessness. There are quite a few sites we can use for the subcutaneous cannula, preferably abdomen and upper thighs. But if the patient is quite delirious and there's a chance of removing, we can use the back over the scapula area. In addition to morphine and some midazolam, if the patient is a bit more well, we can ask them or teach them controlled breathing with a inspiration time of counting for 2 and expiration counting for 4. We can change the position, what is best for the patient. So not every patient will be happier at a propped up position. COPD, they will prefer a leaning forward position, the tripod position, so we can facilitate that. Ask them to do pursed lip expiration. And one important thing in palliative medicine is using the fan therapy, ideally a handheld fan. So the wind blowing from the fan hitting the cheek will give a lot of comfort and reduce the feeling of breathlessness. There is quite a few research and there's evidence for this. Good symptomatic relief with the fan therapy. Nebulizers can be used if the patient is tolerating and the symptoms are getting better with nebulizers. If they have a sticky sputum, we can use carbocysteine or saline nebulizers. And for a dry cough, treatment would be cough suppressants like morphine and codeine. Sometimes people have a bad smell, halitosis, which definitely affect their dignity when people come to see him. So chlorhexidine mouth care will help with halitosis. And of course, now noisy breathing. He was having noisy breathing and wife was very concerned and distressed about it. It's called death rattle, the sound people make from the secretions in the upper airways when they are dying. Patients are too weak at this stage to clear their throat. So saliva and mucus invariably get collected in their upper airways and the throat. This creates this characteristic sound when the air passes over them. The important thing here is death rattle can be really distressing for the bystanders, but it does not cause any pain or discomfort for the dying patient. So what are we going to do? We have to reassure the family and say, yes, it's quite distressing for you, but we can assure you that the patient is not getting distressed due to that. A gentle suction, if that doesn't cause any distress, can be helpful. And to reduce secretions, we can use hyoscine injections, 20 milligram, again using the subcutaneous line in the abdomen so that we don't punch him again. But the risk is hyoscine can thicken the mucus and cause a sticky phlegm, which is not ideal. So we need to be careful. And if they are on any fluids, it's better to stop because fluids can increase the secretion load. So stop any fluids if there's death rattle. Let me go through the key symptoms at end of life in general now, taking a break from the case scenarios. The 5 main symptoms at end of life are pain, breathlessness, agitation or anxiety, nausea and vomiting, and secretions. So our main aim would be to look into this and address these issues. So the main medications we use for these symptoms, for pain, we use morphine. For breathlessness, again, morphine. Agitation and anxiety, depending on what is causing that, we use either haloperidol or midazolam. For nausea and vomiting, it's either metoclopramide or haloperidol are the cornerstone of treatment. And for secretions, it's hyoscine injections. We are going to another case scenario now. This is the case scenario 3. A 58-year-old female patient with metastatic breast cancer. She's not for any more active treatment and she's admitted with sepsis. We have tried antibiotics and everything failed and she is now dying. Her main worry is the severe back pain which is happening due to the bone mets she is having. So let's go through the management of this severe back pain in end of life. So the cornerstone again in managing pain at end of life is morphine. We again can use the oral solution or the immediate release tablet, 2.5 to 5 milligrams, and use it every 2 hours as needed. But if the oral route is not feasible, we can use subcutaneous morphine, 2.5 to 5 milligrams, and which can be given hourly until the patient's symptoms resolves. Important step in managing pain at end of life is being able to check with the patient, trying to give the pain medications before they scream in pain. So don't wait for them to scream in pain or ask for painkillers. Be proactive and ask the patient and give pain relief even if there's slightest of pain. And of course, we can use pain in anticipation, especially when we are moving the patient, like before cleaning, before turning in the bed, give some morphine that will help immensely. But a patient with constant pain, giving hourly boluses will not help. So this is where the concept of continuous subcutaneous infusions comes, which is called CSCI. So if we use more than 2 boluses, that means patient will need a continuous infusion. So CSCI, we normally use in the other countries what we call a LMET34 syringe driver, which is shown on infusion pump, which is shown on the picture, which comes with a 21 milliliter syringe. But of course, we can use the infusion pumps we have in our setting with a 50 ml syringe. We insert a separate cannula in the tummy for this. So the patient will have 2 subcutaneous butterfly cannulas, one for the as needed medications, one for the infusion. The infusion normally takes about 4 hours to act. So always give boluses for pain until the infusion kicks in. And the advantage is in the same syringe, we can mix medicines like morphine, midazolam, hyoscine, and haloperidol. So we can mix everything and put bit more saline or distilled water to mix it and start the infusion. So all the symptoms can be addressed at the same time. The problem with morphine is renal impairment. In our settings, we see a lot of patients with renal failure. So the problem is that this will cause accumulation of toxic metabolites, which are neurotoxins, and patient will have opioid toxicity, which is quite distressing. So best thing is to start oxycodone at this stage if available, but it's not very well available in our setting because oxycodone is an opioid like morphine, but it is metabolized in the liver. Just want to say, if we have codeine, codeine acts by getting converted to morphine in the liver. So if there's renal failure, just like we can't use morphine, we should not be using codeine as well. If the EGFR is less than 30, then we are facing a big problem. So ideal setting, we should be giving fentanyl boluses, which of course we can give in most of our hospitals. But if they need an infusion, it should be an alfentanil infusion. So it's a bit tricky, but of course, we can use our common sense and see what is worse at this stage, whether it's the pain or the risk of neurotoxins. One important aspect in pain management at end of life is identify pain in those who cannot communicate. Because most of our patients who are actively dying will not be able to communicate and tell ask for pain relief, tell that they are in pain. Just like our patient in case scenario 1. So the clue was his GCS. So he was making responses for the pain. So he was sensing pain, although he cannot say that. So there are quite a lot of scoring systems or tools in the web we can use for accurately checking whether the patient needs pain relief. A good one is $2, which gives a comprehensive assessment of patient's pain, but it's a very busy setting at our hospital, so I suggest a common sense approach. So if you look at this face at the right hand corner, anyone can say that this patient is in a lot of pain, although she may not be able to communicate that back to the doctor. So please remember, patient can be in pain even when they can't tell you. Some clues to find that the patient is in a bit of pain. One is protective body postures. So they might turn away from the doctor, trying to stay curled up so that people can't approach the patient. They might try to protect the sore areas, like covering the abdomen, covering their hand. They might resist movements if they are especially joint pains. They might resist washing or turning in the bed. Facial expressions, tensed face, grimacing, tears, which all mean they might be in a lot of pain. And of course, physiological parameters like tachycardia, tachypnea also could be due to pain. So it's worth giving some pain relief and see if that settles. A big question in our communities is when the patient is at end of life, should we give fluid or not? I'm again quoting the SLMA guidelines, which says clinically assisted nutrition and hydration are regarded as medical treatment and should be treated in the same way as other medical interventions. So intravenous fluid is considered a medicine. So it's not a basic human right. Giving fluids, there is some benefits, but there's burden as well. There's no studies that have done to check whether this prolongs life. And there's no evidence for or against giving fluids in the literature. Some benefits would be it will reduce the thirst. And of course, because of better circulation, it will reduce the risk of morphine toxicity. But the downside would be it can increase secretion load, which can be quite distressing. It's always good to discuss with the family and see what they feel and explain to them the scenario. Better thing would be to avoid giving fluid because we don't want patient to be having a lot of secretions. But again, sometimes families are so fond of having a saline and they might take that as like the only thing that can be done for the patient. So if they are insisting and you don't see a clear risk in it, can give subcutaneous fluid again through the subcutaneous cannula. We can give about 500 ml twice a day over like 8 to 10 hours. But of course, for thirst, there are other options. We can wet the patient's lips with a soap, water soaked gauze. We can put small pieces of ice so that they can suck on that ice, which will reduce the thirst. And if available, the drug of choice would be artificial saliva gel. Okay, we are moving into another case scenario. So the case scenario 4, a 75-year-old gentleman with type 2 diabetes who is on mixed insulin, 30 units morning, 20 vesper, is now end of life with terminal heart failure. Because of this heart failure, he is having an ICD and a permanent pacemaker in place. Now he is actively dying. We have discussed with the family. He started on a syringe driver and symptoms are managed accordingly. He's able to take some fluids, so the family is giving some fruit juice and a soup when possible. First question is, how to manage his diabetes? So he is on mixed insulin, quite a big dose. So the goals of managing diabetes at end of life. One is to prevent hypos because they can be distressing, and also to prevent hyperglycemic emergencies like DKA because that too can cause quite a lot of distress. But we are not worried about secondary prevention developing complications in the future. So what's the plan for this patient? So the plan is to start once a day insulin in the morning and try to use a long-acting insulin. We take 75% of the total dose at the start, and then we check the fasting capillary blood sugar every morning. And depending on the capillary blood sugar, so our target is to keep the sugars around roughly 140 to 350 or 8 to 20 millimoles per liter. And we check the morning fasting capillary blood sugars, and depending on that, if it's within range, we give the same dose every morning. But if it is less, we can change the dose by 10 to 20% up or down according to the fasting capillary blood glucose. If this was a type 1 diabetic patient, it's still the same rule. We calculate 75% of the insulin requirement, use it every morning, and then we check the fasting capillary blood sugars and adjust the dose accordingly. Let's look at some other scenarios in diabetes. So if the patient was on diet control or was only on metformin for the diabetes, we just stop the medicines or stop his diet control. And there's no need of monitoring blood sugars because he's having very low risk of going into a hyperglycemic emergency. Suppose the patient was on other or multiple oral hypoglycemic agents. Again, we stop all the medications and we try to get an idea about patient's blood sugar by checking the capillary blood sugars 3 times a day for a day. And if the sugars are high, more than 350, we give 6 units of soluble insulin. If the patient needs 2 6-unit soluble insulin boluses, then we put them on a once a day morning long-acting insulin like our type 1 patients and patients who are on mixed insulin. Right, we are going to go back to this case. So in addition to diabetes, he had another issue. So the patient had an ICD and a pacemaker. What are the options we have for them? So we do not need an ICD in a patient who is at end of life because it's going to give inappropriate shocks and patient will die with a lot of distress. So how to prevent them getting the inappropriate shocks? This is by keeping a magnet on the chest on top of the ICD. In most countries, we have these ring magnets, which is also available at NHSL. So we can place it and over the device and tape it so that patient will not get inappropriate shocks. Then we call the electrocardiophysiologist and ask them to come and officially deactivate. But we know now for certain that it will not give shocks until the person comes and deactivates it. Regarding the pacemaker, we should let it function normally, because one thing, it's going to prevent patient getting distressing symptoms, especially of bradycardias and syncopal attacks. And also, it's not going to prevent death. Having a pacemaker, still the patient will die when the time comes. So we don't have to do anything for the pacemaker, but if there's an ICD, put a magnet and tape it. Right. We're going to move into another case scenario. This is an 84-year-old lady. Previously had a large left side MCA infarct as seen on the CT. She was bedbound, non-verbal at home, coming with seizures. She got an aspiration pneumonia while having the seizures. She is now end of life. How are we going to manage the seizures at end of life? Because this can be really distressing for both the patient and the family. So 10 to 15% of people who at end of life, we assume that they will get seizures. And if they have a brain tumor, 70% of them will get a seizure. The best treatment at end of life for seizures is midazolam, 5 milligrams given subcutaneously as needed, and we can give every 10 minutes for the seizures. And if we need more than 2 midazolam boluses, we can put them again on a syringe driver, the SLCI, and give midazolam 20 to 30 milligrams according to the requirement through the syringe driver over 24 hours, and keep doing that until the patient passes away. Suppose the patient was already on antiepileptics. What we commonly use is levetiracetam. So if the patient was on levetiracetam orally, it's important that we keep them on levetiracetam until they die, because it will be really distressing to get a seizure. So the conversion, again, we give it subcutaneously. So the conversion is 1 to 1. So if they were on 1 gram PD, that's 2 grams for 24 hours. So we give 2 grams in the syringe driver over 24 hours. But key thing here is they will need a separate syringe driver. We can't mix levetiracetam with other anticipatory medications we used. If we are newly starting someone on levetiracetam, we start with 1 gram over 24-hour dose. Similarly, if the patient was on valproate, again, the conversion is 1 to 1 from oral to subcutaneous. And if we are starting new, again, we give 1 gram over 24 hours. Right, we are going to move into another case scenario. It's a 75-year-old man who is a Jehovah's Witness, coming with a massive upper GI bleed. According to his religious beliefs, he clearly mentions that he does not want any blood or blood products, even if the situation is life-threatening. He's very clear on that, and we completely respect his belief. And he rapidly deteriorates. He's not fit for a scope. So he is managed as an end-of-life patient. Are there specific things in this kind of scenario that we need to follow, other than these ethical aspects? So bleeding at end of life, it's one of the most frightening ways to die for the patient and also for the family. People can end up having post-traumatic stress disorder, seeing people bleeding to death. It could be a GI bleed, a massive hemoptysis, eroding skin ulcers, malignancies, ruptured aneurysms. There are multiple causes where people die due to bleeding. The most important thing here is to reduce the anxiety, because patient will be really anxious. So talk to the patient, keep talking to the patient, try to keep him as calm as possible. Somebody has to stay with the patient. Never leave a patient who is bleeding to death alone. It can be horrifying for the patient. And of course, we can use some midazolam to calm him down. And most of the time, they will need some midazolam because it's very difficult to calm down a patient who is bleeding to death just by talking to them. So use midazolam 2 to 5 milligrams every hour. And if they need a lot of midazolam, just go for a syringe driver. IV tranexamic acid may help if there's a cannula present, but it's not going to change the prognosis much. And also local pressure, if compressible, again, we have to take into account how much discomfort it's going to cause and whether it will change the course of management or course of the patient's prognosis. One more thing I want to tell about end-of-life bleeding is cover the patient with a dark cloth. Don't cover him with a white cloth. Just showing two pictures of blood on a white bed sheet versus blood on a black blanket. So seeing this red spots of blood will raise the anxiety level over the roof for both the patient and the family. So make sure you have some dark clothes in your emergency department. In case somebody is bleeding to death, just cover him with dark clothes. Don't cover him with light colored clothes because it can make a big difference for their final final journey. Let's talk about another related topic. With anxiety comes terminal agitation. So it's a well-known fact that people can get really agitated at their very last moment. It could be due to anxiety, it could be just due to delirium, confusion, or most of the time it will be a combination of both. What we use normally for this is midazolam, 2.5 to 5 milligrams subcutaneously, especially if it's more anxiety related, and can go to a syringe drive as needed. And if it's more delirium related or confusion related, we can use haloperidol. But if there's both, just give both of them. Important thing is to treat the terminal agitation. Vomiting, if they have few days of life left, we manage according to the possible cause. So if it's likely a stasis, gastric stasis, functional bowel obstruction, we use prokinetics like metoclopramide and domperidone. If it's chemo related, ondansetron would be better. Increased intracranial pressure, dexamethasone and cyclizine are the drugs of choice. And if it's metabolic like CKD, hypercalcemia, haloperidol will be the best drug. But if they're in last hours, just give haloperidol or metoclopramide, whatever is easily feasible, because then the cost doesn't really matter. All what we need to do is to reduce the distress. A quick word about patients with Parkinson's disease who are reaching end of life. Try to give the dopa agonist medications as long as possible because it's going to prevent them getting stiff and getting quite distressed. If available, rotigotine patch is the patch we can use like in this picture, which will slowly release dopamine agonist to the bloodstream. So we convert the dopamine agonist by 50 to 1 for the patch. An important thing to remember is avoid haloperidol, metoclopramide, stametil. These are dopa antagonists. So we should not give them in a patient with Parkinson's disease because it's going to create a worsening of his Parkinson's symptoms. So for vomiting, we can use ondansetron and of course domperidone because it does not cross the blood-brain barrier. For delirium, rather than haloperidol, it's better to use quetiapine because that will help with the delirium and not worsen the Parkinson's symptoms. I'll just quickly go through some other symptoms because we are approaching the end of our talk and see what we can do. Hiccups is a common symptom at the end of life. So if it's more gastric distension, metoclopramide, domperidone kind of treatment. If it's phrenic nerve irritation, we can use medicines like baclofen and gabapentin. If it's due to systemic causes, haloperidol, largactil, and midazolam. End of life, haloperidol and midazolam, if we can't find a cause, would be okay. If they have pruritus, then we use antihistamines and SSRIs. Mirtazapine also is very good for pruritus. But specifically, if it's due to renal failure, gabapentin will help. If it's cholestasis, rifampicin is a good choice. Some people get very severe itching due to morphine, and then ondansetron is the drug of choice. If this is due to lymphoma B symptoms, prednisolone will be the drug of choice. So lastly, few more symptoms. If they get cramps, quinine sulfate is the best drug to control cramps in last few days of life. For stiffness, like in a MS patient, give baclofen, tizanidine, or gabapentin. Dysphagia, if it's a tumor obstruction, dexamethasone. If it's due to spasms, sublingual GTN will help. Paraneoplastic sweating can be really distressing. Treatments include naproxen, venlafaxine, amitriptyline, and gabapentin. And for severe anorexia, we can use dexamethasone 4 milligram once a day for a week and then wean off. So in summary, important things are identifying that this patient is dying, define the goals for the management, very clear discussions with the family, and ask about what would be the patient's best interest. Stop all the unnecessary maneuvers that will add to the distress. Watch out for the symptoms and treat them appropriately. And keep in mind, subcutaneous route is very, very helpful in managing end-of-life patients. So, this is a situation which we can say nothing to do, but it's not nothing to do. It's a situation where a lot can be done and there's a lot to avoid. It's not a no point situation. It's a situation where there's a huge purpose of treating and treating correctly. So it's not mukut karla vadak na, it's a lot to do. There's only one opportunity to get it right for one patient for their lifetime. And there's no second chance. Just keep in mind, there'll be no second chance to get it correct. So going from this end, so I think it may be more beneficial to go to this end. Thank you very much.
Thank you very much, Dr. Pamuditha, for this interesting, informative, and insightful case-based discussion and the lecture. I hope the audience benefited a lot with this delivery. And we have several questions. So before going to questions, let me, as I told you, let me share the QR code for the CPD points. So while we are discussing the questions, so I will forward the questions to Dr. Pamuditha. While we are discussing the questions, you can scan the QR code and fill the Google form and obtain the, yes. Can you see the QR code?
It was Sahan, but now it's not there.
It's not allowed to display.
Pamuditha has he?
Yeah, he has.
Unshared.
Maybe I can keep it like this so you can see
Now
the,
it's there.
Yeah.
yes. So I think we can't slide show it. And there's a Google link as well in the chat box. So you can also click the Google link and access the Google form. But make sure that you fill it once and there will be no further you will not be allowed to respond again. And so you, automatically you will get the certificate with CPD points to your email account, email address, and this will be active only for 1 hour. After that, you will not be able to access the Google link. So moving on to the questions, I think, so I will forward the questions from the beginning to Dr. Pamuditha. So first question, in the context of the Sri Lankan legislative aspects, is there any legal background for DNR in Sri Lanka? Is DNR legislation in the works to be introduced in Sri Lanka?
Thank you very much for that question. I intentionally avoided talking about it because actually there is no legal background at the moment. The main reason is there's no court cases taken up on this aspect. So most of the legal background comes from the previous court cases, what they decided, but so far there's no court cases taken up. So what we have is the SLMA guideline, and there is a quite a famous counselor who has been involved in making this guideline. So that's one thing where we can go back to, but in proper like legal terms, there is no legal background, but there is a lot of efforts on trying to get this correct by the different colleges, including our college and the CCP.
Thank you. So I will move on to the next question. In the first case, after explaining the situation for the guardian, he requests to take the patient home. What should be our approach?
So it's something that has happened quite often, and like even this week we have discharged a couple of patients who are end of life for home. It depends on what the patient's wishes again. It's not what is most convenient to the family. So some people, we can imagine from their lifestyles that they would want to die at home, or some people have mentioned it to the family. So in that scenario, if we think the symptom burden is not that high, I suggest it's okay to discharge, but I would get them to sign the ticket, BHT, and say that they understand all this and they are happy to take the patient. It's not like going against medical advice, but definitely get everything signed by the family. In other countries, of course, that's the goal, to get the patient to die at their own bed. So there's a lot of services available, community palliative care team. So that's the main goal in managing palliative care patients, get them back to their own bed, to their own surroundings for death. But here it depends on your clinical judgment. But problem is if they develop symptoms, if they get a seizure at home, then everybody will be in trouble. So one important thing is, will they survive the journey home? What is your clinical judgment? And then will they get a lot of symptoms? Depending on that, we can send some people home after getting the family to write on the ticket everything that we have explained and discussed.
Okay, thank you. So the next question, when giving morphine at deathbed for pain relief, why should we worry about renal impairment? If morphine is superior to all others, why we think of renal damage and think of alternatives?
It's not the renal damage. In a patient with renal failure, the accumulation of toxic metabolites can cause a lot of side effects, including respiratory depression, vomiting, and also patient, if they were conscious before this, they can get really agitated, confused, and unconscious. So the balancing between benefits of morphine and the side effect is the issue. We are not worried about a drug causing renal failure. The worry is if they have renal failure, whether the toxic metabolites will cause more distress than the benefit.
Yes, thank you. So the next question, somebody has appreciated the informative lecture. Legally, we cannot take decisions of DNR in Sri Lanka. After all about measures, do we do unnecessary CPR and causing severe distress for patients who will be getting no benefit and futile? Any discussion going on about the issue in college level? I think
I think the answer will be yes. There is discussions and we are trying to get this corrected, but at the moment we don't have a proper legal background.
thank you very much for that answer. And Dr. Pamuditha, and the next question is about yes, the secretions. There are a lot of secretions. Can suction and nebulization help it? What do you think about think of antibiotic nebulization once or twice a day with bronchodilators?
If the secretions are very upper respiratory and can be done with a very gentle suction, yes, it will help. Nebulization will help with thick secretions to thin the secretions. But if they're already thin secretions, then it will not help. And antibiotic nebulizers, honestly, I don't know whether it reduces the symptom burden because we are not worried about treating an infection. So I'm not sure about it. And bronchodilators, as I mentioned, yes, definitely. If the patient is tolerating and if we can see there's a symptom relief, yes. But also we need to keep in mind what bronchoconstriction or like asthma causes is breathlessness and anxiety. We can try to treat asthma also. We can treat the symptoms, and at very end of life, it's more like symptom based than treating the cause.
Can we document DNAR in BHD legally in end of life?
Again, given that we don't have a legal background, I don't know honestly whether how it will be discussed in a court case because it hasn't happened before. All we know is we go by the standard pillars of ethical guidance, which has we do things for patients' beneficence and non-malfeasance. So we should not do things that will harm the patient, and we should take decisions that are benefited for the patients. But only way to know how a judge will give a verdict is when that case is taken up in a court case. So at the moment, I'm not sure. So everything, make sure that we get written and signed by the family after the discussion.
Thank you. Is there a practice of advanced directives in Sri Lanka for a sound of mind patient who we have decided on end of life care?
As far as I know, no.
And let me forward the next question. There are a couple of questions. So it has been noticed in wards sometimes that there are multiple family members around the patient when the decision of end of life hasn't been determined yet. In that scenario, would you do the initial discussion with the immediate family or all present? Also, practically, would you do it in the ward or is there some place more proper in most hospitals?
I will ask the family, or like say if the husband is dying, I'll ask the wife, what do you want? Do you want all of them, or do you want to discuss? Because legally we don't have a next of kin situation. So I would just ask them what they want. And if there's a dispute, it's always better to be on the safe side and not do things which will put you in trouble, given that we don't have a legal backing. But if all the family members are in the same page, then it's okay to discuss with everyone. But if they are giving different opinions, then it's going to be really tough to make a decision. But yeah, we can ask everyone if they're happy. And better to do it away from the bedside, because people say, like, when they are dying, the last sense to go is hearing. So people might still hear what we discuss. So I will never discuss it in the bedside.
Thank you. So are we commonly using butterfly cannulas and 50 ml syringes for CSCI? In our wards, we are not commonly using CSCI due to the non-availability of subcutaneous cannulas.
So it's a bit of an issue actually, because we don't have proper subcutaneous cannulas. We have tried, and there's the palliative care unit at NHSL, where Sithira Seneviratna is doing a great job. I have had chats with him, and he said he has been successful in using this. So there's not a lot of evidence, and it is not ideal, but yeah, we can try to use.
And are there any legal provisions in Sri Lanka to withdraw treatment or withhold treatment?
Again, as I said, we go by the ethical uh, what the ethical documents. So we do things for non-maleficence and beneficence, and we don't have a proper legal background. So if in even in other countries, like, people can go to courts, and then you have to prove that we have done the correct thing for the patient. So it's not like if we do something, people can't sue us. It's just that we need to do the correct thing from the basic ethical principles, so that if something happens, we can prove that in the court. So it can be either way. Like, if somebody might sue you for giving CPR on a patient who is definitely dying. So it's not always doing more that will help you. So it's best to take the decision, the best for the best interest of the patient, and make sure we have an agreement with the family. If I wouldn't go and do a DNR if the family says, no, you shouldn't do it. We need CPR, because I don't want to get into trouble and be tested in the court. So it's a difficult scenario. So, but most of the time, so far, I have never met somebody who, a family member, after good explanation, said, no, I need CPR. So people, when they say when we discuss everything clearly, they are very thankful and said, that's very good to know. So in that case, don't do anything. But yeah, there's no legal background, so I can't give a clear answer.
I think the next question was also asked about the doing starting CPR on the request of the family member. So I think the answer was given. So I will forward the last question. So in the case scenario with the cancer patient in sepsis with no acute active cancer treatment, is it justifiable to give up to go for end of life? Since even in cancer care, palliative care, maintenance therapy in palliative intent is available, and aggressive management of neutropenic sepsis with even ICU care can overcome sepsis provided facilities are available.
Definitely. So we told in that case scenario that we have tried antibiotics and she is not responding. So if they come, even if they have cancer, if it's a reversible cause, we definitely do need to treat. It's a different story whether the patient is fit for a ITU admission or not. But definitely, if it's a reversible cause, and if the patient doesn't say that she doesn't need and like treatment. So some people will say don't give any treatment. They have right to refuse. But if they accept treatment, if there's a reversible cause, definitely treat. So in the case scenario, we discuss about someone who failed antibiotic therapy as well.
Thank you very much. For two questions asked on whether this lecture is shared, so or uploaded to YouTube. Yes, we will upload the lecture video to the Sri Lanka College of Internal Medicine YouTube channel. If you wish to access, you can just uh, use the YouTube video to review again. So that brings to the end of the questions, the Q&A session. So let me thank Dr. Pamuditha Madanayake again for doing this informative and insightful lecture for the audience on behalf of the Sri Lanka College of Internal Medicine. Thank you very much for spending your valuable time with us today and delivering this wonderful lecture. And I
Thank you
also
very much.
thank all the Thank you. And I also thank all the participants who were actively involved in forwarding your questions. And I hope this lecture has been a very good opportunity for you all to bring up an insight to the management of patients at their end of life. So with that, I would like to conclude this session. So thank you very much, everyone, and have a pleasant good night. Thank you.